couple of announcements before introducing our grand round speaker. Couple of upcoming meetings. One is the fact that on January 9th or on June 9th, there'll be the annual meeting of the department and the Institute. We'll be doing this mostly or largely virtually, but it'll be an annual meeting. It'll follow kind of a similar format, but not be the usual kind of content that we cover in the annual meetings. So I know you won't want to miss that and want to stay for every second of the 90 minutes that the meeting elapses. In addition, there is an event this Thursday on May 27th from 12 to 1, which will be a virtual panel on issues relating to racial discrimination, stress in the workplace, issues of coping with the events that we've been through in the past year. And this is kind of an offshoot of COPE Columbia. The panel is going to be led by Patrice Malone, an assistant professor, Warren Ng, an associate professor, and Ofoli Mabako, who has 2 fellowships, currently in infectious disease and at the HIV Center currently, and is Robert Remian's mentee. And then in addition, let's see, where is this? A program that's in formation. It's actually been developed conceptually and hasn't been formally launched, is the Center for the Prevention and Treatment of Depression, co-led by John Mann and Randy Auerbach. And to sort of launch this, they've established and gone live with a website, but also organized a Depression Research Summit, which is going to be held on June 9th, 16th, and 23rd, so 3 days. And it has an all-star cast of researchers with expertise in all aspects of mood disorders research from across the country. It's on the website, so you can find that. It's in, I'm sure, the Columbia News or NISP announcements that go out each week. So I wouldn't want to, that's something that's definitely worth attending all or as much of it as you can. Finally, before getting to the program, I just want to say that we've had an incredible year in terms of the duress we've been under and the crises we've been needed to manage, and it continues even as the infection rate in COVID wanes, and it continues in the sense that we're seeing a lot of social unrest and really unfortunate and shameful kinds of behavior in the form of bias expressions, both verbally, physically, and so forth. And they seem to be culminating or rising, even on the anniversary of the death of George Floyd, which was, a seminal event that set off a lot of the focus on the concerns of these inequities that have historically existed in society. And even though, the initial focus may have been an African-American who was victimized, it's now extended to other ethnic and religious groups. And we'll say we're going to focus to some degree on topics like this at the annual meeting, but I just wanted to call attention to this, say that I definitely appreciate how it makes our lives, as we just go through our normal professional and personal lives, more difficult to have these things occurring in all around us in society. And even though we're trying to fulfill important functions within the area of healthcare and mental health care, and can't directly have the levers of power and influence to rein these things in. This is something that within our environment, our department, our institute, our organizational structures, that is not just not tolerated, it's abhorrent. and will be addressed in any way should such manifestations occur. So this is not just virtue signaling. This is a statement of fact and reality. And I certainly hope that our society redirects itself, and this is simply a bad patch we're going through, and that there'll be a corrective course that soon eventuates. Next week, we have an interesting speaker in that it is a former Columbia faculty member from the School of Public Health who about a year or so ago took on the position of the CEO and president of the Fountain House, which is this historical clubhouse type program in Midtown Manhattan, which has a real interesting legendary role in mental health care. And he'll be talking about, this is Ashwin Vasan, talking about serious mental illness as a social justice and public health issue, a new direction for Fountain House. But today we have our own Aimee Campbell, who is an associate professor of clinical psychiatric social work in psychiatry at Columbia and in the area of substance abuse or substance use disorders. Aimee hails from Washington State, but came after getting her bachelor's degree at the University of Washington, came east to Columbia, where she received advanced degrees up to a PhD from the School of Social Work, was recruited into the then Division of Substance Abuse by Ned Nunez, Van Levin, Herb Kleber, and has had really a stellar career with an incredible productivity in a whole variety of areas that are understudied, and she's brought incredible skill and ability to both in terms of her research acumen as well as her grant getting capability. I'm not going to go into an extensive listing of all she's done, but just read a couple of the projects she's involved with to give you a sense of the breadth and depth of what she's been up to. So in no particular order, she's a co-investigator on a Northeast Caribbean AIDS Education and Training Center. She is similarly a co-investigator on translational research training in addictions for racial and ethnic minorities program affiliated with City College, Columbia, and Rutgers. She is involved with Ned Nunez and the NIDA Clinical Trials Network. She's the PI of a web-based addiction treatment program for cultural adaptation with American Indians from NIDA, and also is a co-investigator on the mega opiate project led by Nabila El-Bassel, Ned Nunez, Van Levin, etc., which is called CHASE, an innovative county level public health response to the opioid epidemic in New York State. Did I get the last one right, Aimee?
Yeah, I think so. Yeah, the Healing Communities Study is the shortened version of that long title.
Thank you. The Healing Community Study. So, Aimee has been somebody who's been extraordinarily successful. And, I'm sort of embarrassed to admit it until a few years ago wasn't somebody I had been familiar with in terms of her work, but somebody that, maybe other people as well, hadn't noticed, because she's modest, keeps focused on her work, but is somebody well worth getting to know and to understanding the work that she's done. And she's going to share some of it today, which is focused on culturally centering medications for opioid use disorder, community engaged implementation research with tribal partners. So the American Indian component of her various research populations. So please welcome Aimee Campbell. And Aimee, take it away.
Great. Just get my slides up here. All right. Well, good morning, everyone. It's really great to be with you. I'm really honored to be presenting to our department at Ground Rounds, and thank you, Dr. Lieberman, for the nice introduction. And happy to get to know anyone more as we move forward. So today I'm going to be talking a little bit about a current study, an ongoing study that I'm involved with. I'm a co-lead investigator on this, and the lead investigator is Dr. Kamala Venner, a colleague of mine from the University of New Mexico. who does a lot of research with American Indian and Alaska Natives, especially around adaptation of evidence-based practices. And so the study I'm going to talk about today is really, I'll focus on the development of an implementation intervention to help integrate medications for opioid use disorder into healthcare clinics that serve American Indian and Alaska Native communities. We're about finished with phase one, the development phase, and so that's what I'll focus on today, but I'll spend a few minutes at the end of my presentation just talking about the testing component of this study as well. And today I'm pleased also, I'll be joined by the CEO of the Native American Community Clinic in Minneapolis, Dr. Anthony Stately. I think we may have gotten a Central Time Zone, Eastern Time Zone mix up, so I hope that he'll be joining shortly. And he's going to talk for a little bit at the end towards the end of the presentation about from the community perspective of engaging in research partnerships. So just want to acknowledge funding for this work from the National Institute on Drug Abuse Clinical Trials Network, and I'll talk a little bit about the CTN and kind of the importance of CTN funding for this work a little bit later. That's just the agenda for today's presentation. I'll start by providing some information about American Indian Alaska Native tribal nations and some context for really understanding the issues related to opioid use disorder, the opioid overdose epidemic, and some background on from earlier research to really understand some of the challenges and facilitators that tribal communities have encountered in terms of integrating medications for opioid use disorder into their treatment programs. I'll then briefly touch upon community engaged research and specifically community-based participatory research. And then I'll present how we're using CBPR in our current study to develop and test an implementation intervention for health clinics. And then we'll finish up with Dr. Stately, hopefully, to add some additional context on how best to engage and collaborate with tribal community partners in the conduct of research. So before we start the presentation, I'd like to ask us to all stop for a moment and acknowledge the original inhabitants of the land on which Columbia now resides. And I want to thank the School of Nursing for including this acknowledgement on their website. So land acknowledgements remind us of the history of Indigenous peoples on this land and the truths around colonization, forced removal, and genocide. Land acknowledgements should not be viewed as just a recognition of the past, as colonization is really an ongoing process. So this acknowledgement really allows us to think about the history of the places that we reside, to focus on ways in which Indigenous people actively are working to heal historical trauma, and our own participation moving forward to become more aware and to act towards a more just future. So we acknowledge the traditional unceded territory of the Lenape people on which we learn, work, and gather. Lenape means real person or original person, and it is important to remember that Lenape collectively are a living and breathing community. Let us honor their legacy. Let us commit ourselves to the struggle against forces that have dispossessed the Lenape and other Indigenous people of their land. Thank you. So as a reminder, and just to kind of give some background of when we talk about American Indians and Alaska Natives and tribal nations, there's currently 574 federally recognized sovereign tribal nations. 231 of those are located in Alaska. And tribal nations are diverse with unique histories, culture, and language. There's numerous terms that kind of get, I think, thrown around a little bit in terms of how American Indian and Alaska Native folks identify. You'll find that they often use very different terms as well. But the government uses American Indian and Alaska Native for reporting purposes, specifically around race. And this is for people in the continental US and Alaska. So Native Americans is actually a broader term and includes US residents who are from Mexico, Central and South America. And here in New York State, we actually, we have 9 tribal nations, one of which is recognized by the state, but not currently the federal government. And the names of those tribal nations are listed at the bottom of this slide. And here we can see a map that shows the tribal nations of New York State. You'll note relatively small sizes of the reservation lands that have been retained by these tribal nations. And I'll just point out the people of 6 nations, also known as the Iroquois Confederacy or the Iroquois League, included tribes from central and western New York, the Mohawk, Oneida, Onondaga, Cayuga, the Seneca, and later a 6th tribal nation, the Tuscaroras. And these 6 nations are characterized as one of the world's oldest participatory democracies and often thought to have helped inform the US Constitution. So there are currently about 5.2 million people in the US who identify as American Indian or Alaska Native, approximately 1.7% of the population. And you can see here that pre-contact by colonizers, there are estimates of anywhere from 1.5 to 20 million indigenous peoples in what is now the US. This dropped to around less than 250,000 at the turn of the 20th century due to the impact of colonization practices. Currently, about 3/4 of American Indian Alaska Native people live off tribal lands, so the vast majority, many in metropolitan areas. And again, as a result of relocation, forced removals, and the need for economic opportunity. And you can see at the bottom here, the states with the greatest percentage of American Indian Alaska Native peoples. This include Alaska, New Mexico, and South Dakota. So this slide points out some of the ongoing consequences of colonization, oppression, and discrimination, as well as the significant underfunding historically of health and social resources for American Indian Alaska Native people, including the Indian Health Service, the Bureau of Indian Affairs, and the Bureau of Indian Education. A side note, I'll just highlight this really actually underscores the significance of the appointment and confirmation of Deb Haaland to lead the U.S. Department of the Interior, which oversees the BIA and the BIE. And so, as I'm sure you know, Secretary Haaland is the first Native American to serve as cabinet secretary and is a member of the Pueblo of Laguna, located in New Mexico. So that's just a very exciting development in terms of who has oversight over these federal institutions. And again, what we see here are significant disparities in many of the social determinants of health that we typically look at, including median income, education, and I think strikingly here, the poverty rate, which is 2 times that of the national poverty rate among American Indians and Alaska Natives. And of course, in the ongoing discrimination, racial trauma, and historical trauma also factor in significantly. So moving to talk a little bit about substance use specifically, and following, I think from the health and social inequities we just looked at, we also see significant disparities in the rate of substance use disorders and the consequences of substance use disorders among American Indians and Alaska Natives. And that's actually despite American Indians and Alaska Natives having the highest rates abstinence from drugs and alcohol. And these disparities, are noted. You can see 10% of American Indian Alaska Native adults with substance use disorder, about 2 percentage points higher than the general population, and opioid misuse similarly. Substance use disorders are associated with other health disparities as well, as of course we know, including a higher mortality rate as a result of accidents, injuries, and suicide. Treatment for substance use disorders is often hampered by accessibility issues, resource and workforce issues, the availability of treatment in rural areas, and appropriate and acceptable treatment in urban areas for American Indians and Alaska Natives, where, as we noted, most live. So Yeah.
Just, I don't know if you were going to mention it, but do you know what the survival rates are for this population?
So the age or their
The longevity, in other words, I'm thinking of the the work that came out of forgetting their names, the Princeton sociology and deaths of despair. I mean, it's an aggregation of contributory factors to survival, but I wondered if you knew what the average longevity of men and women were.
I don't. I have not looked at that recently. Yeah, my guess, given all the statistics that we just looked at, that it's going to be significantly lower and probably similar to other folks of color that kind of suffer similar disparities in health and access to health.
Okay, thanks.
Yeah. So just moving on to opioids more specifically, this is a graph of opioid-related overdose death rates from 1999 to 2017. This is a very common figure. I'm sure many of you are familiar with it. The darker blue line represents American Indian, Alaska Native overdose rates. You can see the red arrow there. And second only to white overdose rates as of 2017. And I'll also point out, of course, the recent steep increase of overdose rates among Black and African American folks, as well as Hispanic and Latinx.
Are those include heroin, or is it just synthetic opiates?
This would be any opioid-related overdose. So it would include both heroin and synthetic opioids. And we know that synthetic opioids, especially in the last several years, are involved in most opioid-related overdose deaths, as well as many other overdose deaths.
Also, Amy, we can welcome your colleague who has just joined us.
Oh, that's great. Good to hear. Welcome to Dr. Stately.
Hi, good morning. Sorry I'm late.
No problem. Okay, and I think as Dr. Lieberman was alluding to, our concerns can continue to deepen as we look at increases in overdoses over the last year related to COVID and related to synthetic opioids as well. So it's just important to note that because tribal nations are diverse, we do see variability in the opioid epidemic across states, but also among tribes within states. And this is data from 2018, just giving you a sense of where we're seeing some of the highest opioid overdose rates among American Indian and Alaska Natives, including Maine, Minnesota, where Dr. Stately's program is, and Washington State. So I also wanted to share this more recent data on methamphetamine related deaths. This shows a graph for men, but it's virtually the same findings among women. American Indian, Alaska Native people are represented by the orange line at the top of the graph. And as you can see, there's been historical disparity in methamphetamine deaths among American Indians and Alaska Natives, which appears to be broadening quite significantly since 2015. So I put this up there just to note for several reasons. One, we know that people often use polysubstances and opioid synthetics are now quite commonly found in other drugs, including stimulants. So it's important to consider this as we think about our treatment approaches. And second, stimulant use disorders are becoming a primary focus in our communities and in all communities across the US. But this has been a concern among American Indian and Alaska Native communities for at least 15 or 20 years or more. Mm-hmm. And this particular data, the publication was co-authored by Dr. Nora Volkow, the director of NIDA, so federal agencies are well aware of these increases too. But again, I would just note that American Indians and Alaska Natives have been struggling with this for some time. So I want to just highlight a couple of things here and bring COVID into the picture. It's hard not to over the last year or so. But what we see with this COVID data are that health inequities also continued into this public health crisis. So this figure produced by the Kaiser Family Foundation compares different racial ethnic groups to white Americans for COVID cases, hospitalizations, and death. American Indians and Alaska Natives are the first bar on each of these figures. And what we see here is that the risk of getting COVID, of being hospitalized with COVID and dying of COVID is anywhere from 1.7 to 3.7 times higher of their white counterparts. And of course, we've seen similar disparities among other racial ethnic groups. And I point that out because we see a different story here when we look at vaccine rollout. So this figure reports vaccination rates from December through early May by race and ethnicity. The figure shows those receiving at least one dose of vaccine in the first figure and those that are fully vaccinated in the second. And the yellow line represents American Indians and Alaska Natives, with rates of full vaccination at this time point at 30%, the highest across any racial or ethnic group. So what happened with tribal rollout of the vaccine? So several things have been noted. One is that there was sufficient supply sent to the Indian Health Service to roll out in tribal communities. So the resources were there and made available. Two, tribes specifically built vaccination efforts on existing trusted community resources and used culturally relevant messaging to try to get the word out to their communities. So they focus specifically on local, meaningful, what works for our communities. And then third, there was a tribal COVID-19 task force that put forth prioritization strategies, administration, distribution, and communication plans. And of course, they prioritized elders, as many communities did with vaccine rollout. But they also thought about things like speakers of native languages to protect against further cultural and traditional losses. So really putting the priorities and values of the communities in the forefront. So in an article summarizing this information from Kaiser Family Foundation, the authors note, and it's noted there on the right of the slide, the success tribes have achieved in vaccinating their communities provide lessons learned that may help inform broader vaccination efforts going forward.
Is there a convening authority that did this across the different tribes?
I think at the IHS level, yes. And then, but I think most specifically, it was really individual tribal nations that prioritized and rolled out the vaccine in their communities in ways that really focused on where they thought the need and priorities should be.
Yeah, I think it was really driven by tribal consultation with the Indian Health Service. And then in the majority of cities where there's tribally run clinics, those clinics might, in urban areas, those might be IHS designated clinics, or they're part of the tribal urban sort of like the ITCUs. If you are IHS designated clinic, then you got your allocation directly from IHS. You circumvented the distribution from the federal government to the state, and then circumvented that distribution process, which I think was, I think it's safe to say that was a major. There were lots of major faux pas in the early rollout between the feds and the states.
You'd say
So
that
we were able to circumvent that process. Really helped tribes respond more rapidly to the problem.
Yeah. So I don't want to disrupt the thing, but just one question that it prompts is,
Okay.
among various underserved ethnic or racial groups, there's an aversion oftentimes, due to fear, bias, historical experiences, as well as just lack of knowledge and information about whether Western medicine is going to be helpful. In this case, obviously, that wasn't the case. Is that generally true for American Indian or Native American peoples, that they may not have access to the healthcare, but they don't have an aversion to it for other types of historical bias or experiential reasons?
Well, I think the lesson here is that when the federal government gave the tribes and the tribal organizations like mine the latitude to decide how they were going to sort of deliver the intervention, when they gave us the resources to get the job done and to sort of kind of like, allow us to use our expertise and our knowledge and our experience and wisdom, and then just for lack of sort of like, nuanced conversation, just get the hell out of the way and let us do our work. What we were able to do is we were able to show that we can accomplish some tremendous successes. And I think the lesson there is that, it's interesting. I've had a couple conversations with people about like, IHS can, this pandemic and our ability to respond to it in the way in which we responded to it is a good demonstration model for like why healthcare for all might be a really good way to solve some of our bigger problems in healthcare.
Yeah.
So anyway, that's another conversation for another day.
No, thank you so much, Anthony. It's a real treat to have your expertise throughout this. So thank you.
You're welcome.
And so I think building upon what Dr. Stately said, this is something similar that we want to try to do. The goal of this particular project that I'll talk about, and that Dr. Stately is involved is really increasing the acceptability and availability of medications for opioid use disorder in collaboration with communities. And so we're hoping to do something similar here. It's not so much that there is, kind of a view of Western medicine that we don't want any of that, but it has to be tailored and integrated into wellness paradigms that are appropriate for local communities.
Mm-hmm.
So I want to shift a bit here to talk about, again, the fit of medications for opioid use disorder. So that was a nice segue in American Indian Alaska Native communities. And again, just as a reminder, we're talking about FDA-approved medications for opioid use disorder, so methadone, naltrexone, and primarily in healthcare clinics, buprenorphine. So this slide presents some conclusions drawn from a NIDA Indian Health Service convened meeting in 2017. And this was actually chaired by Dr. Benner, who's the lead investigator of this study. And this just shows some of the results of, we published the proceedings of this meeting, and I was a co-author on that publication. And the goal of the meeting was really to identify research recommendations from tribal community providers, as well as Native and non-Native researchers. And this meeting really was the forerunner to the study that we're talking about today. So attendees really talked about the mismatch, as Dr. Lieberman, as you kind of suggested, between kind of Western secular reductionistic medical models and more holistic medicine traditions in American Indian Alaska Native communities. And then there's also the perceived gap between traditional medicinal plants and healing practices and Western medications. And so being able to bridge some of these traditions and understand how they might be integrated among this group, I thought this was really key to addressing the opioid epidemic in tribal communities. Similar findings were also reported in a recent scoping review to understand the opioid use disorder continuum of care among American Indian Alaska Native communities and tribal settings. And again, with recommendations for better integration of Western medications, and this included foundations in culturally grounded traditions that respect and incorporate resources and assets, integration of medications for opioid use disorder into traditional wellness paradigms that encompass mind, body, spirit, and person. And then the desire also for a strong behavioral health component. And we hear that over and over. And then finally, a recent needs assessment was conducted in California to understand barriers and facilitators of addressing opioid use disorder in tribal communities. And you'll see, the challenges and risk factors are similar to kind of what we've already talked through before. But the group also highlighted key protective factors that could be leveraged to promote opioid use disorder treatment outcomes, including cultural traditions, a focus on family and community cohesion, providing education to providers, especially non-Native providers, around the traditions of American Indian Alaska Native consumers, and following an integrated model of care. So as we began to think about our study, it was clear that developing an implementation intervention for tribal serving health clinics needed to be community engaged from start to finish, to have something that would really work in Native communities. So just a couple minutes here to just kind of ground ourselves in community engaged research. The CDC defines community engagement as working collaboratively and through groups to address issues affecting the well-being of those people, with the goal of building trust, enlisting new resources and allies, creating better communication, and improving health outcomes through lasting collaborations. So it's not just asking for community input. It is really a redesign of traditional research participant hierarchies, whereby researchers really become engaged with the community and the community becomes meaningfully engaged in the research. And this is community engaged research has been somewhat limited in substance use disorder research, although there's definitely previous literature. And those prior studies have demonstrated that community engaged research can lead to more effective community responses and likely greater sustainability over time. So a primary community engaged approach is community-based participatory research, which I know many of us are familiar with, or CBPR. This lists the primary tenets of CBPR, and this is really considered a gold standard approach for collaboration with tribal communities, especially given some of the examples of research that was not conducted with trust and transparency among tribal communities. And there are unfortunately numerous examples of that. So the tenets will look familiar based on the background and context we just covered. But the idea is that we're really building upon strengths and resources within each community. And that's giving equal time, not just to what people's concerns are, but to identify assets and how those can be strengthened and built upon. Facilitating collaborative, equitable partnerships. So having discussions about what power sharing looks like and how to place equal emphasis on preferred ways of collaborating and knowledge sharing. Fostering co-learning. And this is just as much about researchers learning as communities learning. And I can attest to this just in the time that we've worked on this study, that I'm sure I've learned far more than anyone else that we've partnered with. Balancing knowledge generation and mutual benefit of all partners. So I think we've all seen and heard about and experienced what I think was known as helicopter research, right? What CBPR promotes is to understand what is a benefit to all partners and then moving in that direction. As we've talked about, focus on local relevance for public health that recognizes social determinants of health, involving systems development. And again, as we've already discussed, many of the challenges that we're talking about are systemic in nature. They're institutionalized. And so really understanding how those systems work and trying to intervene in those systems is key. And disseminating results to all partners and making sure that critical audiences have access to the results of studies and that they're accessible. So moving beyond, obviously, academic presentations and conferences and publications. And then key to this is it involves long-term processes and a commitment to longer-term sustainability. So community engaged research takes time. There's just no getting around that. And so you really need to go into this invested when you engage with communities at this level. So CBPR is a very good fit with implementation science, and we're utilizing implementation science, of course, as we build the intervention for this study. Implementation science, as a reminder, is the systematic study of how to best integrate evidence-based practices into routine clinical care. And implementation strategies to do this are often determined and should be determined in collaboration with community and program partners. So it's really a good fit. There is a movement within implementation science as well to emphasize the ways in which this work can be centered to promote health equity. Just say Rachel Shelton in our Mailman School of Public Health is a key leader in this area. So in our study, we are combining community engagement with implementation science to develop an intervention to increase the successful integration of medications for opioid use disorder in clinical settings serving Native communities. So getting back to the CTN, this is the National Institute on Drug Abuse Clinical Trials Network. Funded this trial for those of you not familiar. It's a network within NIDA comprised of 18 research nodes and affiliated healthcare clinics, health systems, specialty addiction programs. The structure of the CTN really allows for more efficient rollout of multi-site trials. And the aim of the CTN is very closely aligned with what we're doing in this study. So funding from the CTN was really important because they recognized the need for comprehensive intervention development in a study with tribal communities. So this allowed flexibility to utilize community engaged research. So this is the rationale for the study. It's known as CTN 0096. And the aims are, as I mentioned, to develop and then test an implementation intervention to increase medications for opioid use disorder in a way that centers culture and traditional paradigms of wellness. So over the next few slides, we'll just talk a little bit about some of this initial phase 1 development before I turn it over to Dr. Stately. So these were kind of the key components of intervention development, and we're nearing the end of phase 1. So we'll be moving into testing of the intervention in the fall. So we really convened a collaborative board that's kind of the key backbone of the study, promoting, supporting the development of the intervention. We selected our 4 partner clinical sites across the country, worked on obtaining tribal and IRB approvals, developing data use agreements with each of the clinical sites, and some qualitative data collection. This photo is our collaborative board at our first face-to-face meeting, which was in October of 2019 in Albuquerque. So this slide just goes into a little more detail about the collaborative board process and how we've really worked with the collaborative board to develop this initial, to work on this initial phase and develop the intervention. So membership was primarily based on existing networks of individuals that the research team and colleagues knew, and then snowballing techniques to add additional individuals with key areas of expertise. So the collaborative board is comprised primarily of Native folks, but also non-Native researchers and specialists, and includes elders, tribal council members, clinical providers, physicians, implementation specialists, people with lived experience. It has an ethnobotanist on the board and an epidemiologist as well. And as sites were selected to join the study, then several members of those community research teams also joined the collaborative board. Early in the process, we collaborated on a memo of understanding for how the board will function. We elected 2 chair people that would manage any challenges or conflicts. And the process of the collaborative board centers around monthly full board meetings, as well as 3 working groups that meet separately and bring back information to the full board. So I just wanted to present briefly some of the, just a few of the findings that really came out of that initial 2-day face-to-face meeting. And we utilized a qualitative facilitation method. It's known as World Cafe, but it really allows for a flexible approach of folks to meet in small groups, to dialogue, share knowledge, and explore opportunities for more action-oriented research. We also used visual representations for some of these discussions that are, you can see that there on the right of the slide, sometimes known as a mind map. And members identified very similar factors which are responsible for opioid use disorder in tribal communities, including mental health issues, historical and intergenerational trauma, family and cultural erosion, discrimination, stereotyping within the healthcare system, and also numerous cultural strengths that could be leveraged during treatment. And we've talked about many of those already. The mind map on this slide demonstrates a way of thinking that really centers holistic wellness. So we had a number of these, some of which had medications for opioid use disorder in the center. And what we noted is that with this particular mind map, as compared to the one that centered medications, there were fewer negative terms that came up in the mind map. So things like shame, judgment, stigma. There was a focus really on the centrality of elders, spirituality, teachings, and culture. Whereas the medication map really focused on education, information sharing, some of those sorts of things. And so I think, coming out of that meeting, the quote that's listed here, and you all can read it for yourself, really represents the overall sentiment of the collaborative board in needing to culturally center treatment. And this meeting really gave us an initial pathway for thinking about how to do that in collaboration with our partners. But just briefly, the three work groups, I just want to talk about some of the things that they're specifically focused on. So we have a traditional practices work group that identifies traditional healing practices and activities, but probably even more importantly, how those practices can support health and mental health care, and ways in which we can also integrate family and community and culture into healthcare settings. They also help to adapt a community health assessment that will be used with our sites, and providing training activities that support the integration of Indigenous ways of healing. And one example of this is the work group has currently putting together a series of vignettes that will help us to train providers and dialogue around how we work with consumers. We also had a measurement work group that was really key in identifying appropriate measures, and they worked on developing our qualitative interview guides, as well as role playing to make sure that our measures and our qualitative interview guides were acceptable and appropriate and not too burdensome. And finally, we have an implementation process work group. And as the name would suggest, this is really focused on utilizing implementation science strategies and processes to provide a structure for the intervention, and then ways in which we can integrate the work of the other work groups. So just before I turn it over to Dr. Stately, this slide just kind of summarizes some of the key components of the study that we've really integrated to try to adhere as close as possible to CBPR tenets. It's always, I think, a work in progress to adhere to CBPR. There's a continuum, of course, but we've done some very key things to try to move forward on that, including using the collaborative board as the main oversight body. The collaborative board members are paid as consultants on this study, so they really are members of the research team. We've integrated the study sites into the intervention development. Budgetary considerations were really, and Dr. Stately could probably talk more about this, but budgetary considerations for the site to run the study, but also to think about ways in which that could build capacity within the sites at the same time. And tailored data use and ownership agreements with each of the clinical sites so that they really met their needs and preferences. So I want to turn it over to Dr. Stately now, and I know he didn't get a specific introduction, so I'll just say before you start, Dr. Stately, that as you know, you received your PhD in clinical psychology from California School of Professional Psychology at Alia International University, currently the CEO of the Native American Community Clinic in South Minneapolis, which provides primary care, dental care, and behavioral health services to the Twin Cities Native American community. A number of prior positions, including the Director of Behavioral Health Programs at a tribal organization in Minnesota, and a research scientist and director of the Center for Translational Research at the Indigenous Wellness Research Institute at the University of Washington. So we both spent time there. He's taught in clinical graduate programs at numerous universities and served as a consultant and advisor to the CDC and SAMHSA, as well as numerous NGOs and nonprofits that deliver health services to tribal and indigenous communities. So so pleased that you were able to join us, and if you want to just to take a few minutes to talk a little bit about community engaged research from your perspective.
Sure. And sorry I didn't have time to put together a slide deck for you, but I just I thought my time would be better spent sort of just having a conversation with you and telling you what my experience has been over the last couple of years in my specific role since leaving a research institution and being back in the community and directing healthcare services to a significantly underserved and underrepresented population. But also talk a little bit about my relationship, our NAC's relationship with Dr. Venner and Dr. Campbell, and this project specifically has been a significant contrast to some of the other work we've been doing with clinical research. So this project, we really started this process about, God, it feels like a year and a half ago. Like just the process of doing site selection felt like a long, arduous process in the sense of like we had to comb our EMR and do a bunch of other things, but we were, I'll tell you that like the key to sort of my participation in this project really was, like, I didn't know Dr. Campbell before this project. It really was my prior relationship with Dr. Venner. And I've known Dr. Venner for about 20 years. I met her when I was still in, maybe a little bit longer than that, because I met her when I was in graduate school, and I had like my last couple of years of graduate school and my first couple of years out of graduate school, I was part of a cohort that UMN brought together for a mentorship program in research. And that's how long ago we met during that process. I think it was about 25 years ago. So I've known her for quite some time, and I've followed her career, I've used her curriculum, and I've been doing a lot of training and other clinical work throughout all of my sort of posts, even up to this one, around utilizing motivational interviewing from a culturally crafted perspective on, in patient engagement, and utilizing the patient's own motivations to change their behaviors, health behaviors that, and adopt those health behaviors. And of course, so I knew Dr. Venner's work for a really long time, knew her work and knew her personally, which helped a lot. And I think that's probably one of the key things I would also say is that in Native communities where, we focus on the relationship between us and the investigators. I think like what we want to do is have a good relationship. Parenthetically, I would say that recently we've had a couple of other different studies. Folks kind of approached the clinic, approached me, asked me if we want to do clinical research. And an example is we were asked by the University of Minnesota researcher to partner on a implementation study, clinical implementation study of low dose cancer screenings for the clinic. We have some of the highest rates of lung cancer and the highest rates of smoking in our Native community. And of course I thought, yes, of course, this makes a lot of sense. Super important for us to do. That person didn't really have a Native person or another investigator in the project, leading that project. And so one of the challenges was right off the bat was like, just sort of like having conversations with them about orientating their aims to be more specific to like specifically how this would benefit our community. Like I was really clear about the benefit to science and really clear about the benefit to her individually as a scientist. But I was like, you're asking us to provide access to you for patients. You're asking us to do some work here. And I'm not going to do that to just improve your career as a scientist. I'm doing that. My focus is on taking care of my community and protecting my community and making sure that anything that we do that we're going to invest time and resources into is going to benefit them. So that was difficult conversations to have, but the researchers sort of kind of rose to the occasion. One of the challenges that we had specifically in that particular sort of study, in contrast to this study, was when it came time for us to actually start the process, the university said, "Oh, we're not going to cover the governmental review process. We're not going to take on IRB. That's the operation of the study is taking place outside of our institution at your site, so we're going to make you responsible for IRB." And I was like, that was a major sticking point, right? Because nobody had thought, including the researcher, had thought to include money in the budget for us to pay for a private IRB, and we certainly are, as a small institution, we didn't have IRB. So that was a really long conversation we had to have with the institution about, like, reminding them that you had come to us and asked us to do this research, and now you're sort of like hamstringing us and tying us up from moving forward by not providing us the resource to be able to do it. Parenthetically, or in contrast, like the CTN process has been sort of like I think it really, like, one of the things I think that I love about this study is there's a really highly engaged collaborative board process. Like, the board, all of the members of the different sites really contribute to sort of like helping to identify problems in the study process, come up with solutions, and they really contribute to the overall effectiveness of the design, and also the overall effectiveness of the study itself. And so, it was helpful to be involved in this study, because I had something to compare when I went back to the vice president of research at the University of Minnesota. And I was like, look, I'm doing something with, UNM and our University of New Mexico and Columbia. And this process is very different. Like, these are also very well-resourced institutions that understand what it means to be in a community, trying to do community-based intervention, implementation, research, and investing in that. And they're thousands of miles away from me, and you're right in my backyard, and you can't accomplish that. So I think part of it is having this conversation about, like, how important it is to sort of really think through, like, from the very beginning. Obviously, the difference between, I think, this study and also some of the other studies, and namely this other one, is that we were involved in those conversations from the very beginning. Like, the investigator didn't already come up with the design and then approach us. They involved us in the process of designing the study. They involved us in the process of contributing to everything from recruitment to data collection and a few other things. And I think when I think about the importance of that from the perspective of a community-based organization, so Native people have historically had very poor relationships with research institutions. They've either, historically misused their data, misrepresented them in dissemination, are misinterpreted, and then caused great harm to communities. And then around something like substance abuse and mental health issues, a subject that is highly stigmatizing to the group already because of some of the historical issues that have happened in the past around research and services, service delivery. It's important to sort of make sure that that the voice of Indigenous people are front and center in those conversations at the beginning of the process, because we have we will have, the organizations themselves will have a hard time sort of engaging the community and selling the idea to the community, or encouraging the community to sort of like participate, if we can't demonstrate for ourselves that we've done a good job of protecting them from the beginning. And, you know, when we talk about protection of community, a lot, and I think that sometimes people don't, that we don't have, like, we often don't think of real world sort of like ways in which that show up. But you know, we have some real clear demonstrations of that nationally. At, like, you know, an example would be like a really noteworthy case that probably practically everybody knows about, because it had a lot of traction in the news, which is the you know, the case in the Southwest. I think it was with the Zuni people, where folks took, or might be, now that I think about it, I think it's Cuna Pueblo. The researchers allowed secondary research done on genetic material that without the consent of the tribe and without the consent of the participants. And then when that became sort of knowledgeable, when we found that information out, it was that type of sort of like level of finding or news really rocked the Native community. Like, you know, I think that challenged us greatly about our willingness to sort of engage in biomedical research, right? So much so that here we are, almost, I think 15 years later, still challenged by trying to figure out how to, you know, do this work well and build trust with the community, because they felt so harmed by that process. But it can even be something as simple as, like, a year ago, the Minnesota Department of Health, who I have good relationships with them. I have a really great relationship with one of the tribal representative or leads at the MDH, but they released a report about the syphilis outbreak in Mille Lacs County, in Mille Lacs, and they used the word Mille Lacs. They weren't really specific. They didn't say it in the county. They said in Mille Lacs, and Mille Lacs County and Mille Lacs Indian tribe have the same name. They share the same name. And what happened as a result of that, you know, is that across the state, you know, it sort of was interpreted that the tribe had an outbreak of syphilis, that they were having all kinds of other challenges that were contributing to the syphilis outbreak. And one of the ways it hurt not just the sort of the reputation of the tribal people is that it also had a business impact on their gaming operation. People started, they tracked over, you know, a 3 or 4 month process after that report was released, and they found that a significant reduction in participation and foot traffic to their casino on their tribal land. And so some of that, like, we don't often think about, like, how the things that the ways in which we report data, the ways in which we disseminate information that we collect in tribal communities, how that actually impacts tribes, unless we are being really thoughtful and engaging tribes and tribal representative groups like urban populations in those conversations about how we tell the story of the data that we've collected, right? And think through what are the challenges that might arise in the way in which we release that information. So we wanted, like, part of the really critical piece here is, like, is full engagement from the very beginning. And I've had a couple of really bad experiences over the last few years, such that I've told my entire leadership staff, like, we are not doing any other research other than community-based research. I don't care who it is. I don't care if it's, you know, I don't care if it's Mayo. I don't care if it's, you know, anyone. Like, we're not doing it unless we are a full participant, and it's designed to answer questions that are important to us, not just to the researcher, answer questions that are important to our community. And the research design doesn't do something to build our capacity as an institution or as a community to provide and to do this work ourselves. So that's really important, because we want to be acknowledged as knowledge production. You know, a big part of sciences, our research sciences, the production or the codification of knowledge, right? And we as Native people, we have a story to tell, and we have knowledge to share as well. And we want to be the not just known as the purveyors of that knowledge. We want to be known as the producers of that knowledge, right? And the original intelligence. We want to be acknowledged for intellectual property, right? The way in which indigenous ways of knowing have been around for 10,000, 25,000 years. We want to make sure that we want to protect those things, but we also want to be acknowledged for the contribution. And so those are really important things to sort of have discussions about from the moment that somebody approaches me and asks me if I want to do a research project. And I thought originally that it was going to be really challenging to sort of do more research because of that. But ironically, since I've adopted that stance, in the last year and a half, I've been being asked to do more research because of that. But I'm also being really, really selective of like who I participate with, because being a full partner is really important. I take the role and responsibility of being the lead of an organization that serves the community very seriously. And the reason I do that also isn't just because of like, some institutional guideline. I happen to have been born and raised in South Minneapolis, in the same neighborhood of the place where our clinic is situated. The folks who walk into my clinic every single day are not just figurative relatives; they are actual relatives. I have nieces and aunties and uncles and grandparents and grandchildren who are the children of my siblings and my cousins. And those I take seriously the responsibility to care for them as much as I care for the other folks. So it's kind of like I may be a little bit different in that regard because I'm serving in an organization that is a member of my community, but I think a lot of tribal members probably feel that same way. So.
Thank you so much, Dr. Stately and Dr. Campbell. That was really a remarkable talk, and it's just so helpful to hear how thoughtful you are in approaching this work, and and trying to develop a program of research and treatment to such a underserved population. And it's an area that we don't hear enough about, or at least I can say for myself that I don't know enough about. So really want to thank you for taking the time. I know that I have a question, but I wanted to first turn it over to Dr. Lieberman to see if he had any thoughts or questions.
Sure.
Yeah, two comments, Jonathan. So Dr. Stately and Aimee, thank you. That was a wonderful presentation. In terms of what you were just commenting on, the importance of being kind of culturally sensitive and collaborative and designing and engaging early yourselves in the research planning process. That's a generic element of research, clinical research that exists. In other words, clinicians and researchers, there's always a little bit of a gap or tension and a town gown split. And so it's, but in the case of doing research within a specific population, and particularly a population which historically has been exploited or mistreated, it's a much more sensitive and more complicated thing. So that should be, I mean, any researcher who doesn't appreciate that going in is not worth their salt. There should be like the ante of coming in to propose collaborative research should be a certain level of awareness to begin with. But my question is this: with the success that you had with the COVID vaccine, and given the fact that healthcare in our country is not handled well for the whole population, let alone for specific underserved populations, would it be possible, like the VA is a closed system. They don't do a good job either, but they have a closed system that they have control over. Could you design your own healthcare system if the resources were given to you?
Yeah, I think that, so one of the things I think that's probably, the answer is yes, I believe we can do that. But I also think that something that might make the Indian Health Service, or at least that process different than the VA, is that so any tribe that is either is directly receiving either funding from IHS, or they have an IHS clinic on their tribal land, they have compacts with the United States. So the relationship between them and the United States is one of government to government relationship. It's kind of like an acknowledgement of their understanding of sovereignty. So it's not as though like the IHS gets to say, like, we're going to tell you what to do with the resources we give you. Mm-hmm. There's a consultation process that happens between the tribes and IHS. There's a consultation process that happens between the tribes and other sort of federal entities that allow tribes to sort of say, these are the resources that we need. This is how we want to do the work. This is like, this is the way we want the work to be accomplished, right? And I think that probably is a little bit different than something like a VA system, where you have probably you don't have that process isn't right, there.
Right. No, the administrative structure sounds like it's more distributed and diffused. And the COVID situation was kind of a unique instance that you could take advantage of.
What happened with COVID is, what we learned is, like, you gave the resources to the tribe or the tribal clinic and you allowed them to sort of, like, you gave them the latitude to sort of use the resources in the way that they understood best. Mm-hmm. So you gave, like, you gave localized control over a specific issue and asked them to let them use their wisdom and their experience and their knowledge to sort of make the best decisions about, who to vaccinate first, or who to test first, those kinds of things, and how to do that. And rather than sort of like a top-down approach where it's directed.
Sure.
And it would likely work well in a lot of communities, not just Native communities.
Yeah, exactly. I think it's a change in the way that you think about, like, the way that you think about participatory health. Like, one of the things I've said to my clinic, I think that it's actually reoriented a lot of our capacity over the last couple of years since I stepped in the role of CEO, is like, I made one pitch to my leadership staff. I said, I wonder what would happen to the way we delivered service and the way people engaged in our services if we stopped calling patients and we started treating them as relatives, like just a basic Indigenous principle, like, treat these people like they're your relatives. I want you to, when they come into your office, I want you to think, like, what kind of conversation would I have with my mom, my grandparent, my child, and how would I show compassion and kindness and all those other kinds of things that I would do to a family member. And if we do that, I think they become more engaged in the process, right? It also opens up a different way of thinking about how to do medicine.
Yeah.
I think one of the things that Dr. Venner has always said to Anthony around the work that we're doing is that, we're engaged with Native communities for this particular study, but what comes out of this will likely be good to disseminate more broadly to all sorts of communities, because the idea is really centered on the individual in front of you, the community, and how to engage with them on in a holistic way, which is, I think, what you would do if you had a relative sitting in front of you.
I think when you use a relational model, you get a lot more traction in the community. You get a lot more traction and a lot more mileage out of it. So, yeah.
So I wanted to ask sort of a question that's somewhat related to that topic. So if I understand correctly, it sounds like the IHS is doing a pretty good job in terms of trying to engage with communities and taking an approach that's respectful of local knowledge. And I guess I'm wondering, is that a sort of a more recent approach that the IHS has taken, or historically has that, I guess I'm wondering, historically, have they taken a more top-down, heavy-handed approach?
Well, I will tell you this, so my perspective is that it's a fairly recent sort of process over the last maybe 5 to 10 years. My clinic specifically, I will tell you, is not an IHS designated clinic. So we have a sister clinic that's close by, that is the IHS designated clinic for the urban area. It's called Indian Health Board of Minneapolis. But NAC gets, we partner with tribes, so that's how we become sort of like IHS eligible for some funding mechanisms. And but one of the things that we were able to do here in Minnesota that was, I think, different than probably maybe, I don't know, maybe other, I think that a lot of the other urban sites and like Seattle Indian Health Board and Urban Indian Health Institute, that's an IHS designated facility. They're also at FQHC, but like us, but they have that designation. And so what makes us different is that even though we are not an IHS designated facility, we work really closely with our tribal partners on the delivery specifically of our Suboxone and opiate treatment programs. So we work really closely with the local tribes on that project and initiative, and they are IHS designated entities that have the resources that they are able to bring to the conversation and the table in this partnership. But what we have been able to do differently, because we're not an IHS designated facility, like IHS can't tell us like how to structure our programs. So we've been successful, specifically us have been successful at the local level, because we get to operate outside of those guidelines and those structures, specifically sometimes to the detriment of our own selves, because we also don't qualify for some of the bigger awards that they put out. But that's, there's lots of different places where you find money, and I've been pretty successful at that. But the point being is that I think recently, under the leadership of the last IHS director, who was Dr. Michael Wiyaki, he was a CEO of a healthcare center and a hospital before he became, he came up through the ranks. He worked in Sacramento at the community health center level. He worked at an IHS hospital, worked for a large system in Phoenix area office, and then went to headquarters. So I think his experience sort of like of doing that kind of work in lots of different settings really helped him sort of kind of craft a different sort of way of thinking about the allocation of resources and the partnership of tribes. And I'm hopeful that the new IHS director continues that sort of legacy, because it really has changed for many of us the way in which we are able to do our work and serve our people.
Great, thank you. So we only have time for maybe 1 or 2 more questions. So one question that came in was about the differences in the rates of opioid use versus methamphetamine use, and is that primarily attributable to access, and are those trends changing in the opposite direction?
And Anthony, you can weigh in here as well. But I would say that that's access and geographic regions, and the way that opioids, I think, have been deployed throughout the U.S. You do see higher prescription opioid misuse among American Indians and Alaska Natives, as opposed to heroin. And again, I think much of that is geographic, but the methamphetamine and stimulant issue has been around for a very long time. And I think there's some hypotheses around, some of the more rural reservations and, access with moving substances through those types of areas, law enforcement issues and things like that contributed to that kind of longstanding problem. But Dr. Staley? I don't know if you.
Yeah, I think that, so, I mean, I think there's across the United States, there's certainly a different sort of distribution of depending on sort of geographic region, but also the people themselves, right? And some of it is qualitatively different. I think one of the things I think that sort of like stands out for me is specifically so our site, I think what we've seen with the opioid pandemic in South Minneapolis or in Minnesota specifically, is it probably likely started in the early 2000s, late 2000s, early 2010s, primarily being an issue of prescription-based, sort of that was the seeding of the problem. And then when sort of like the spigot was turned off for easy access to prescription opioids, what you have is phenomenologically, I believe this to be true. I'm not quite sure how we're going to, I'd like to design a study where we sort of kind of do this analysis, and I'm hoping that maybe at some point in time we can do this with Dr. Venner and Campbell. I think what happened with NAC is like we in South Minneapolis, one of the things that our clinic did was under the former leadership of the CEO and the CMO, they made the decision to just stop prescribing all pain medication, right? Because they thought the idea was, and it was a good idea, I think, initially for that moment in time, without doing deeper investigation, was, it's a way for us to stop the proliferation of opiates and medications in our community, and thinking that would also curb the OUD problem. Well, what also happened was, it also meant that people they weren't going to pain clinics for that management, and they weren't getting any relief from their pain. And so they had to do things like start, going to the street and to known black markets for those things. And then of course that contributed to the problem of moving people towards the use of heroin. We also have at the same time, over the last 10 years, and you can see it in the data, is that we have one of the highest rates of homelessness over the last 10 years. Native American people in Minneapolis specifically, I think it's true of many of the urban centers across the United States, that Native people are significantly overrepresented in the number of people who are living in unsheltered situations, right? So you have, this confluence of opportunity for where, they're easily preyed upon, and drug cartels. We live right on the I-35W corridor, and we've known that there's a drug highway straight up from through the drug cartels all along the I-35 corridor. And I think that confluence of all these things happening phenomenologically all at the same time just was the foundation for creating a IV drug problem that sort of burgeoned out of control fairly rapidly.
Can I sneak a question in here before you close it out, Jonathan? This is tangential to what you were just talking about, Dr. Staley, but there's been a resurgence in interest in psychedelic drugs of late. And one of the rationales and sources of this issue, has been the fact that they've been used by indigenous peoples ritualistically, plant-based psychedelics for a long time. In my own perspective is that the enthusiasm is pushing things forward and risking leaping ahead of research knowledge about what their true utility and application is and safety is. But do you have any exposure to this process and perspective on it?
Well, I don't personally. But I do know, so I've talked to people who've done like ketamine research and a few other things and have wanted to sort of like partner. And I've stayed really clear from that for lots of reasons. I think this is a common narrative that I've heard for a really long time. I think now is an opportunity for me to sort of kind of also say something that's really critical from a cultural lens about the use of psychedelics in tribal communities. So, the use of peyote and other kinds of things, those substances that cause people to have a psychedelic sort of experience, the sort of the wide scale sort of like dissemination of this idea was really born out of folks who sort of wrote, really, successful books like Carlos Castaneda and a bunch of other people in the 70s and 80s, which is, if I might be so bold to say, is like, they're probably, non-native interlopers that sort of got invited to a ceremony and they maybe participated and they thought, oh, they had an experience and now that felt profound to them. And now they felt like they gave them license to talk about native medicine in a few other ways. It's an example of the proliferation of knowledge, codification of knowledge, and the idea that you can just take that knowledge or that experience and sort of like tell a story about it without really talking to native people and tribal people and consulting them about the use of that knowledge. But our relationship traditionally with those substances is a spiritual relationship, right? It's not about getting high. It's not about pursuing a specific sort of experience other than like, so we believe that medicines have spirit, just like we do. All living things have spirit. And like anything, like any relationship, it could be a good relationship or a bad relationship, right? Depending on the intent and also depending on the way in which you sort of engage and the way you respect it or don't respect it. And so some of that gets lost in those conversations, I think, generally when you sort of don't bring in actually like an elder and other people who are knowledgeable about those systems and are knowledgeable about those systems of traditional and indigenous ways of knowing, and just take something and use it as though you divorce it from the context in which it was originally sort of like helpful. And I think that sometimes when we do that to our own detriment, even as indigenous people, right? So
thank you for that.
Wonderful. Thank you so much, Dr. Campbell and Dr. Stately. Thank you for taking the time to join us for Grand Rounds. It's a really terrific presentation. And we will end there and look forward to seeing everyone in a week.
Great. Thanks so much. And thank you, Dr. Stately. Really appreciate it.
Thank you. I appreciate having the opportunity.